Okay. Good morning, friends. This is the 5th annual conference of Not Daily. 5th annual conference of Not Daily Physician Forum. Not Daily Physician Forum, you know, is an organization of physicians in the North Delhi. We are doing for the last, all the conferences very successfully with the large number of delegates, 400 to 500 delegates in attendance. We will be starting the session, and this time we have done something new like ECG quiz. Then I've got Insulin Workshop, and finally by Mukesh Bhatia, quiz, medical quiz. So there's a new addition this year, and we're starting in another 5 minutes because things are getting clear. So another 5 minutes will be starting. So all who are outside having tea and breakfast, please come inside. You can have tea inside also. Thank you.
हेलो ये फिल्म देख हेलो हेलो चेक 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 हेलो हेलो चेक 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 हेलो 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 चेक 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 1 2 3 हेलो चेक 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 हेलो 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 चेक 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 हेलो 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 चेक 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 हेलो 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 चेक 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 हेलो 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 चेक 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 1 2 3 हेलो हेलो चेक 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 1 2 3 हेलो 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 चेक 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 1 2 3 हेलो 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 ठीक है
लगा लूं मैं तभी मुझे कहते हैं
हेलो all the delegates are requested to come inside the hall with their breakfast plates. All the delegates are requested to come inside with their breakfast plates, please. We're going to start the session.
हमारा फेमस था कि एक को ढूंढना दूसरे को ढूंढो दोनों पैनेटिक घंटा पर होंगे ऐसी थी पूरी कैजुअलिटी संभाल दी थी उसके बाद हम कहते अब हमारी ब्रेक हम घूमने जाएंगे हम वो पीछे चाइनीज खाने जाएंगे या सोनी बेकर्स में जाएंगे हमारी नहीं बीएसआई I took my
Two days could be months.
Yeah. वो बड़ा खुश है। Yeah. सबको ये कहता है, कहते मैंने डॉक्टर पढ़ना के कहने पे कराई है। बाद में उसका कनेक्ट निकला है, तो फिर इनकी क्या नाम है इनका, कार्डियोलॉजी जिन्होंने की है। विशाल ने कहता माथुर ने किया, डॉक्टर माथुर ने। डॉक्टर माथुर की वाइफ भी लॉयर है। हाँ, वो लॉयर कनेक्ट निकला है। पर वो कहता ही है, कहता बाद में मेरी बात हुई ना, कहते मैंने सिर्फ डॉक्टर पढ़ना के कारण कराया, कहते मेरे को उन पे कॉन्फिडेंस हो गया। तो किडनी का इशू है। हाँ जी सर, आई एम रेडी, कोई दिक्कत नहीं सर, चालू करो सर। मैं बहुत खुश हूँ सर, मेरे को तो 10 लोग भी होते मैं अच्छे से करूंगी। अब शुरू कराओ, मुझे बरेली जाना। नहीं तो शुरू कर दो, सब बरेली जाना है। हाँ, लीव टुडे एट 1 o'clock।
हमारा प्रेसिडेंट भी क्या हो रहा है?
They've already become late.
Once again, good morning. Now we are starting Ecg Workshop. What is the repeat Ecg quiz? The moderator is Dr. Aparna Chiswal. He is a senior consultant cardiac imaging at EP at Fortis Heart Institute. And to inaugurate the session, I invite Dr. Rakesh Sood, President of our Delhi Bishop. Dr. Rakesh Sood, please. Dr. Rakesh Sood is a senior consultant in general medicine at Fortis Hospital, Shalimar Bagh. Dr. Rakesh Sood, please.
After 2 years, when we are coming back with our annual conference, as we expect a lot of you, but we are trying to select topics which are of interest for people. Especially we have added this quiz, and insulin for DNB students for PGs. I hope you will benefit from this. Get the conference open and
Thank you, Dr. I invite Dr. Aparna Chiswal to come on the side. And the chairpersons for this session are Dr. Preetam Gupta. This is an introduction. He is a senior consultant general medicine at Fortis Hospital, Shalimar Bagh. Dr. B.K. Agrawal. He is a senior consultant medicine at Saroj Hospital, Rohini. Dr. Rashi Khare, very young, dynamic cardiologist associated with Fortis Hospital, Shalimar Bagh. And Dr. Samir Mehta is there. I think speaker has not come. Samir Mehta will come, he will join the session. So now I request the chairperson to start the session. Dr. Preetam Gupta, sir, please.
Hello, am I audible now? Good morning to everybody. This is the opening session now. We are going to have Ecg workshop, and the speaker is Dr. Aruna Jaiswal. She is a well-known figure in North Delhi forum. She had been visiting frequently here. She is a basically academician, published lot of papers, and she is working as a principal consultant in Escort Hospital. And she is specialist in electrophysiology and cardiac pacing. With these words, I request Dr. Aparna ji to come on the dais, and she is going to discuss the ECGs on the case basis. So you can have the question after the case is over. If any question or comments are there, after each case, we will give you 1 minute for discussion. Thank you.
Good morning to all of you. Can we have this relay on the screen? I'd like to thank Dr. Chabra, Dr. Sood, Dr. Ananja for giving me this opportunity to be here. And I take great pride in being the opening batsman for the session today, and I wish them a super success. So I think my task today is to walk you through some cases of ECG. Also, I'd like to share with you that the time assigned to me is 40 minutes, so that the program goes on smooth. I'll appreciate if you stop me at the end of 40 minutes because I can go on for the whole day. So I think, can we have the lights a little lesser, please? So I think when we start the session on an ECG and we want to discuss the ECG, we will have to go into the nuances of the conduction system. So what is the electrical conduction system and how does it work? Nishka, it's not working. Give me a moment, please. ये हटा दीजिए.
ये भी electrophysiologist है.
How do you do it? So I think when we talk of the conduction systems, it's important to understand that we spend a few moments here, because it is in this conduction system that all the abnormalities that we see. So if we were to look, I think if I were to compare the conduction system of the heart with the coronary vasculature, I think the conduction system is very fascinating. It is so fascinating, and it was in 1906, as early as maybe about 150 years, that this conduction system holds for us. So if I may show you again, is this that I don't understand what's wrong here. Maybe you should stand here, Rishta. I'm sorry about this. Everything is an animation. Go back. Play, please. So I think what you need to understand is that the electrical system begins from the sinus node. The sinus node is a node which is present at the junction of the right atrium in the superior vena cava. The sinus node is a natural pacemaker of the heart. And what is interesting about the sinus node is that its unique property called automaticity. Now, we all don't have pacemakers, but all of us, our rhythm is regular and keeps moving on. And that is the unique property of our sinus node. The sinus node is like a tadpole. Do we have a pointer, please? The sinus node, can you go back, please? Oh my goodness. Go back. I think this is what happens when you're the first speaker. So please pardon me for this. The sinus node is like a tadpole. It extends from the superior vena cava and goes along the lateral wall of the right atrium. When it gives an electrical impulse by virtue of automaticity, the electrical impulse goes to the right atrium and goes to the atrium. It goes to the left atrium via a specialized conduction system, subsequently activates both the atria. When it activates the atria, this is represented electrically by the formation of a P wave. So as it goes, the first chamber to be activated is the right atrium. So the first half of the P wave is nothing but the electrical activation of the right atrium. Subsequent P wave is the activation of the left atrium. The electrical impulse then reaches the AV node, then the bundle of His, Then it traverses the right and the left bundle. We must spend some moments here. Can you play this, please? We must spend a few moments here. We have to understand in this, leave it, it's okay. We have to understand that in this section of the AV node, it has a unique property of decremental conduction. All of us, as we get older, develop wrinkles on our skin. The heart also develops wrinkles, and they represent themselves as atrial fibrillation. 7% at 70, 8% at 80 will develop atrial fibrillation. We are well aware that our sinus impulse should be between 60 to 100. When you develop atrial fibrillation, the atria contract at 400 to 600 beats a minute. If those electrical impulses were to all go down, we die. So what is the stopgap? Nature's stopgap mechanism such that the atrial fibrillation should not enter the ventricle, and it is the AV node. The AV node has a unique property. It acts as a stopgap. It will not allow the electrical impulses to go down. It has a unique property called decremental conduction. Subsequently is the bundle of his. Now, it's important to understand, as you can see, this is the right bundle and this is the left bundle. Look at the right bundle. Nothing happens to the right bundle. It is called arborization. It arborizes in the distal section into Purkinje fibers to activate the ventricle. But the left bundle very soon arborizes into the left anterior fascicle and left posterior fascicle. So all of you are aware on an ECG that we see left anterior fascicular block. Remember, this is the left anterior fascicle and left posterior fascicle. You must understand, why do you see left anterior fascicular block so much more frequent than compared to left posterior fascicular block? Often you will see right bundle branch block with LAFB, bifascicular block. That means right bundle is diseased and left anterior fascicle is diseased. But what is so unique that the left anterior fascicle gets diseased and not the left posterior fascicle? Because the left anterior fascicle, as you can see, is in close proximation to the aortic valve. The aortic valve gets calcified as we get older. That calcification extends into the left anterior fascicle. First point. Second point, left anterior fascicle has single blood supply. So if that coronary vessel gets diseased, you get left anterior fascicular block. Third point, it is a very thin structure. Left posterior fascicle block is thicker, robust, dual blood supply, away from aortic valve, so it does not get diseased. That's the reason. Once you have understood the electrical system of the heart on the basis of this animation, much is sorted in your mind. One more thing which we must understand is all the electrical impulses arising from the above and in this area will result in a narrow QRS. Remember, all the electrical impulses arising below this, as soon as an electrical impulse, supposing you get an AV nodal block, this is disease, and the electrical impulse arises from this area, you will find a narrow QRS because it is going from the bundle of his into both the bundle branches. But if the patient develops a block below the bundle of his, infrahisian, it will become wide because the electrical impulse will now arise from either of the bundles. So I think having set the stage for that, go to the next slide, please. We have to understand what happens during the next slide, please. Yeah. Can you play this? I've already told you that when the electrical impulse fires the atria, it is responsible for the formation of the P wave, and subsequently, as the electrical impulse goes down into the AV node and the bundle branches, it is responsible for the formation of the PR and subsequently the QRS section. We have to understand that an Ecg leads give us some information. We all are aware that we have these leads, and these leads, the vectors of these leads give us a fair idea. You don't need to memorize all of them, but you should certainly know a few. Remember, the electrical vector of lead 1 is from right to left. Electrical activation of the atria is right to left. Because the lead is also going from right to left, activation is right to left. What do you get? A P wave. You get a positive P wave. If the electrical activation comes from the left atrium, you will get an inverted P waves. Similarly, Lead 2, 3 and AVF are inferior looking leads. Remember the activation of the heart I showed you in the animation. Everything is from above, down, above, down. Hence you get positive P wave and a positive QRS. Having set the stage, we'll go into the next. And this is extremely important again. How do you calculate the rate? When you want to calculate the rate of an ECG, you either have a formula of 1500 divided by small boxes or 300 divided by small boxes. I think everybody is aware of that. So we will move into the case. This is an elderly lady. She's a hypertensive on AC inhibitor 5 milligram twice a day. She comes with fracture neck of femur and she's oliguric. She complains of extreme weakness and nausea. And what you see next is this ECG. So whenever you are called to see this ECG, always try and discern the rhythm. The first thing we like to see is what is the rhythm? Is this a sinus rhythm? Is this an atrial fibrillation? Is it a ventricular rhythm? What is the rhythm? The best lead to follow for the rhythm is long lead 2. Always look here. Can I see P waves? Is every P wave followed by a QRS? How is the QRS morphology? So there is something compelling which is telling me there is a P wave. There is a P wave. The PR interval is more than 200. There is first degree heart block. The QRS is so wide. So go back into the case. She's an elderly lady. She's on AC inhibitors. She is oliguric. So the next thing you want to know is what is the problem that she's having? Is she having a VT? Is it just simple hyperkalemia or is it ventricular flutter? Always keep the case in your perspective. You understand she's oliguric. She's an AC inhibitor. She's fracture neck of femur. With this ECG, always think that she has hyperkalemia. Remember, for all of us, the normal potassium levels are very stringent. They're very little. Like sodium, you go see 130, 140. Potassium, 3.5 to 5.5. Why? Because all of the potassium, as it is depicted here, is intracellular. It is not intravascular. So the potassium levels are very tight, 3.5 to 4.5. And we are well aware that as the potassium increases, it changes the ECG pattern. The first thing to be noticeable on a change of the ECG as the potassium increases is a tall tented T waves. As the potassium continues to increase, we notice that the patient develops a shallower P wave, PR interval prolongation, followed by the patient develops widening of the QRS and subsequently a sine wave. Hyperkalemia is something which should never be missed because it is completely treatable, and if not treated, the patient can potentially die. The next case is a 14-year-old girl. She gives history of recurrent pre-syncope. Now, syncope is something which is often used and misused as a term. Syncope means transient loss of postural tone and consciousness with spontaneous recovery. Please remember that, because we have seen even on death summaries, it is written syncope. But syncope implies transient loss of postural tone and consciousness and spontaneous recovery. So she's having pre-syncope. She's also had syncope. So any patient of any age, when it comes to you with syncope, the first thing you want to delineate is an ECG and an echo. Echo because you want to see does the patient have any structural heart disease. So this is the ECG that this girl has. So if you look into this ECG and let's spend some E waves and what's happening to the R waves. Clearly we can discern that there is bradycardia for her age. For a 14-year-old girl, you expect her heart rate to at least be 90 beats a minute. So when she comes with this ECG, you know that there is bradycardia. Now look carefully and always for rhythm, look at long lead 2. When you look at long lead 2, try and see that are the R waves regular? Yes, the R waves are dot regular. You can see that. The next thing you should want to see, is there a P wave preceding every QRS? Because that's very important. So you can see that there are P waves before the QRS, but the P and the R don't seem to be related. There are P waves, but they don't seem to be related because it is changing. The PR interval is changing. We are well aware the PR interval can change in Wenckebach AV block, but it never happens like this. The PR interval is actually shortening. If you see, look at this PR interval and look at this PR interval. It is shortening while the RR is dot regular. So you want to see where all are my P waves. You see the black dots. There are very many P waves. There is one P here. There is one P on the T. You look carefully on the T wave. Remember, a QRS denotes ventricular depolarization. You are aware that when the ventricle contracts, it forms the QRS. That QRS does not change beat to beat because every ventricular depolarization is the same. Similarly, ventricular repolarization, when the ventricle relaxes, is a T wave. It is not supposed to change on a surface ECG. When the T wave is changing on your surface ECG, it means something is happening inside that T wave. So look at the first T, look at the last T. They are clearly differentiating each other. So there was a P wave within this T. This P wave subsequently came out. Next, please. The red dots are your QRSs. So first thing which you know, the P waves are outnumbering your R waves. There are more P waves, there are lesser R waves. So whenever you see more P waves, lesser R waves, go back to that animation which I showed you in the beginning. That means the atria are contracting more, ventricles are contracting less, and they are not related to each other. The R waves are dot regular, the P waves are dot regular. So this child has what we say a congenital complete heart block, and because this child has had a syncope and a pre-syncope, she deserves a dual chamber pacemaker. Whenever you see congenital complete heart block, many of you would be called to the operation room by the gynecologist or a pre-op because she has to deliver a baby. So whenever you see a congenital complete heart block, remember a congenital complete heart block does not warrant a pacemaker every time. A congenital complete heart block warrants a pacemaker if the patient is symptomatic, if the patient has significant bradycardia, if the patient is developing left ventricular dysfunction on an echo or a cardiomegaly on a chest x-ray, or has wide QRS escape rhythm. What do you see here? The QRS escape is narrow. You are seeing it is a narrow escape. However, she's symptomatic. So it is symptoms as clinicians that we cannot go by. Symptomatic needs a pacemaker. So this is a case of congenital complete heart block. And this is exactly what is happening here, that the electrical impulses are coming from the sinus node, but they are unable to go down. Because they are unable to go down, because there is a problem with the AV node, in this particular child, the escape rhythm came from the AV junctional area. Because the escape came from the AV junctional area, the QRS was narrow. You remember the QRS was narrow. Remember that I always believe that human body is very resilient. It allows us to learn on it. How resilient can a human body be? Similarly, the electrical system is also very resilient. It has so many latent pacemakers. If the sinus node will not work, the AV node will work. If the AV node will not work, the his bundle will work. What is the junctional area? The AV junctional area is this. It is AV node plus the bundle of his. So if this will not work, this will work. If this will not work, our bundle branches will work. If bundle branches will not work, the ventricular myocardium will work. So we don't just die. So there are, but you should as a clinician be able to turn the level of block. So in this young girl, the level of block was at the level of AV node. Why? Go back to the back slide, please. Why? Because her escape was narrow. The QRS that you're seeing is a narrow QRS. Always this you should know. If the QRS is narrow, narrow means less than 120 milliseconds. That means the escape rhythm is arising from the AV junction area. Next slide, please. From this area. So I'll take you. Do we have any questions here? Okay. So can I go on? Yeah. So this is an elderly gentleman, but I don't say elderly. As I'm getting older, the definition of elderly keeps changing. So this is a 70-year-old male whose post-CABG has severe LV dysfunction. I wish to draw your attention here. This is something that we should not let it pass by. When you see an ejection fraction of less than 30 or 35%, you must wake up. Ischemic heart disease with EF less than 30 to 35%, you must remember your cardiologist. You must refer your patient to a cardiologist to consider, does the patient need a defibrillator? Why? I'll show you. So this is an elderly gentleman. EF is significantly compromised, has had one episode of syncope. Please go to the next slide, please. And the monitor is showing this. This patient comes into the emergency room with this ECG. So what you see, the first thing which is striking, the patient has tachycardia. The rate is more than 100 beats a minute. So it is tachycardia. The next thing, is it wide or narrow? The QRS is more than 120 seconds. It's a wide complex tachycardia. Third thing, is it regular? Is it irregular? It is regular. Regular wide complex tachycardia. Tell your fellows, tell your sisters, tell everybody, shut your eyes, diagnose as VT. A regular wide complex tachycardia, if you diagnose as VT, there is a 80 to 90% chance that you are correct. So don't try to do anything. Say this is VT. Next slide, please. Whenever you see, next slide, please. Whenever you see this, you want to now say, and now people get confused. Is it monomorphic? Is it polymorphic? Is it pleomorphic? Is it a VF? Or is it SVT with aberrancy? So this is for the sake of discussion, but you should be aware when you see a regular wide complex tachycardia, VT. Now, focus on lead 2. When you look at lead 2, all the QRSs are identical to each other. When they are identical to each other, they are called monomorphic ventricular tachycardia. So this patient had a monomorphic ventricular tachycardia. When none of them are similar to each other, it is called polymorphic tachycardia. When few of them are similar, it is called pleomorphic ventricular tachycardia. When there is utter chaos in the ventricle, it is called ventricular fibrillation. When there is a morphology pattern of a right or a left bundle with wide QRS, then you say supraventricular tachycardia with aberration. So next slide, please. This is a clear example that this patient is having monomorphic ventricular tachycardia. So monomorphic ventricular tachycardia, the patient comes into the emergency room. The patient's blood pressure is 80. Next slide, please. What is it that you have to understand? First, you have to understand, and I don't want to rush through the presentations, but I think it's important to understand as to why is it that patients who have ischemic cardiomyopathy, have coronary artery disease, have LV dysfunction, are at risk of death because of VT. I think it's very important to understand this. So this is a real cut section by none other than William Stevenson. We consider him a father of electrophysiology. This is a cut section of the heart. What are you seeing in this cut section? It's red, it is nice, healthy myocardium. But what are you seeing this white thing? This white thing is a scar in the ventricular myocardium. The scar forms the perfect electrical milieu to initiate a ventricular tachycardia. When the ventricular tachycardia comes around this, I showed you the animation. For a QRS to be narrow, it has to go through the normal conduction system. Here the QRS is not going through the conduction system. The QRS is being formed within the myocardium. Hence, it will result in a wide complex tachycardia. Next slide, please. There is no way that you can remove this scar. There is no way you can remove this scar. Because there is no way you can remove the scar, ischemic cardiomyopathy is at a risk of ventricular arrhythmias. You must talk about the need of defibrillators in your patients who have ischemic heart disease with LV decompensation. Next slide. E less than 35, please think. So this is just showing you again, this is the scar. And spend a moment here because this is what you see in your clinical practice day in and day out, and you still let the patients go back home without discussing an ICD. It's important to discuss an implantable defibrillator because you and I together can do nothing to remove this scar. The scar is there and this is sitting there, and at any point in time it will go to VT. What is happening here? Look here. What is that scar? This is an animation. Next slide, please. Just click this. Yeah. So this is a healthy myocardium and this is a scar. What is the scar you should see? The scar is a mixture of dead cells, the gray ones, and the alive red cells. Because there is a mixture of these cells, the electrical impulses keep moving there. Because the electrical impulses keep moving there, please. So when this patient comes into your emergency room, will you cardiovert? Will you defibrillate? Will you think I will give Xylocard? Will you think I'll give amiodarone? I will give potassium or magnesium? Remember, any regular wide complex tachycardia with any sign of hemodynamic compromise, the answer, next slide please, the answer is cardiovert. Next slide please. I'd like to share here, play this please. I'll try and show you what is cardioversion and why cardioversion. So there is a circuit here. You have seen this circuit. Now what I'm trying to do, this is me, this is the VT going on. I want to stop this rhythm. I have to stop it now. Why do I have to stop it now? Patient has LV dysfunction. He has heart disease. He's having a VT. His heart rate should be 80. His heart rate is 160. He will not get enough coronary blood supply. To an already compromised heart, he will die. He will die of ventricular fibrillation. So what am I to do? To terminate this rhythm, the most effective, safe way is electrical cardioversion. Please play this again. In an electrical cardioversion, what you do is you select the energy, you synchronize the delivery of this energy on the peak of the R wave. When it is delivered on the peak of the R wave, it terminates the rhythm and the patient comes back into normal sinus rhythm. Now, it's important to understand here because I see in the hospital, especially for the young people sitting in the back, we see in the hospital, in the emergency room, the young fellows who are working there are afraid to use the defibrillator. There should be no fear because the defibrillator will save a life. You should remember, if you see well-formed R waves, be it any rhythm, you always cardiovert the patient. Means you always synchronize the delivery of the energy to the peak of the R wave. Let that be very clear. That is called cardioversion. If there is no R wave, when do you have no R wave? When there is chaos in the ventricle, when there is ventricular fibrillation, there is no R wave, there is complete chaos. If you synchronize the delivery of the energy, the defibrillator will not deliver the energy because it will keep waiting to see an R wave. So remember, in ventricular fibrillation, you defibrillate. What does that mean? You select maximum energy, just deliver the shock to terminate the rhythm. While in ventricular tachycardia or in atrial or in atrial fibrillation, ventricular flutter, everywhere you overt because there are well-formed R waves. Next slide, please. And of course, next slide, please. The treatment of these patients is a defibrillator, and this is how a defibrillator looks like. It's important that you as clinicians, physicians, cardiologists, practicing diabetologists, everybody should know on a chest X-ray, is this a pacemaker or is this a defibrillator? So the answer lies in the size of the device. This device is larger. Why is it large? It has to deliver energy. Do you know when we implant a defibrillator, how much energy it gives? It gives, you know, our electrical sockets give us 220 volts. Do you know how much energy this can give? 700 volts. So it has to jolt, it has to bring the patient alive. That is the amount of energy that this defibrillator has to get. How does it do? It has a battery and it has a capacitor. That capacitor quickly ramps up the energy, delivers the energy to the heart and terminates the rhythm with the help of its own electrical circuitry. And you should be able to discern on a chest X-ray that this is a defibrillator because the device is big and because the lead is different. Look at this lead. There is something happening here and there is something happening here. These are called coils. It is these coils which make a vector and give the energy to the myocardium. So on a chest, next please. On this, you know that this is a defibrillator. If it was a pacemaker, the device would have been smaller and there would have been no coils. If it was a CRTD, as the name implies, cardiac resynchronization therapy, there would have been 3 leads. So you are seeing a single lead, hence this is a defibrillator. I have just 2 minutes left and maybe this will be my last case. This is a 23-year-old asymptomatic woman. I want to ask you, I think I have earned your confidence by now, and I would appreciate if somebody tells, oh, they switched off the lights. I think my time is up. Shall I continue this one? Okay, thank you. So is the ECG abnormal? So look carefully. There should be no hurry. So is the ECG abnormal? Look into the ECG here, and I have given you certain choices: pre-excitation, intermittent pre-excitation, VPCs, or is it an aberrant conduction? So look carefully, look at the first two, look at the next two, look this and look this. Are we all together on this, that this QRS is different from this QRS? I think we're all together on that, right? Next, look at the PR interval of this and look at the PR interval of this. Are we all together that it is different? The PR interval of this is more or less? Less. There is a very small PR interval here, while this is a normal PR interval. Next slide, please. So what is happening here? Can you play this animation? So you remember, I showed you the animation. The electrical circuitry should have gone like this. But here, there is an accessory pathway. There is an extra pathway, which is allowing the electrical impulse to go down to the ventricle, not only from the AV nodal area, but also by the remnant of certain myocardial cells or fibrils, which are between the atrium and the ventricle. I can conclude here, but please remember that during embryological development, we are supposed to have only one electrical gateway between the atria and the ventricles. That electrical gateway is our AV node, bundle of his in this system. Morphologically, when we are born, the whole of myocardium is like a tube. This tube then rotates upon itself and forms the atria and the ventricle. When it forms the atria and the ventricle, there should be no myocardial elements in the annulus between the atrium and the ventricle. If there are any remnants of myocardial fibrils, it is called pre-excitation, because this is non-specialized conduction tissue. Because this is non-specialized conduction tissue, I told you AV node has a unique property of decremental conduction. This tissue does not have that unique property. It allows all the electrical impulse to immediately go down, thus abbreviating the PR interval. And because it activates the myocardium via non-specialized conduction tissue, it results in a broad delta wave, which is subsequently followed by a normal QRS, because the activation then is taken over by the normal conduction system. So that is what is called pre-excitation. Maybe on the next event, when I come back, I will continue from here, because I have only finished 10% of my presentation. And the answer to this is intermittent pre-excitation, because one QRS is having a short PR and the other is normal. So this is called intermittent pre-excitation. So thank you so much for a patient listening.
Thank you, Aparna ma'am. That was a very nicely explained presentation right from the basics to everything we should know, and we'll definitely wait to hear for the rest of the presentation. Thank you very nicely. Thank you. Any questions, please?
Ji, sir. We're wanting to pick up signs of dysautonomia more and more. So I think he has a very pertinent point, and I know where it's coming from, because all of us are together and we have patients coming with diabetic dysfunctions, dysautonomia. So how do you pick up dysautonomic functions of the heart? So I think the first thing that you need to do is do a Holter. A 24-hour Holter gives you, every Holter gives you what is called RR variability. You have to look up at the RR variability, and there is a number there called SDNN, standard deviation of NN. That number should be at least 50 and above. So that's the first sign which you look that, oh, my patient does not have heart rate variability. Does my patient have autonomic dysfunction? Following dysautonomia, you want to now go further. When you want to go further, and you must be aware that there is an autonomic testing lab available in All India Institute of Medical Sciences, where they test only this. However, Why is it that we don't do it? Tests of dysautonomia are also invasive. You have to look at something called baroreflex sensitivity, wherein it becomes invasive. You have to inject medications and you have to see this. So the tests are emerging. We will have more data, but for today, we don't have as much to talk about how do we diagnose. Yes, you can look at the postural drop of blood pressure. That also gives you a sign that my patient may be having some dysautonomia. I think there was a doctor. Ji, doctor.
Yeah, hello. Yeah, in the case where you presented a child with complete heart block. At lesser rate in the ECG than ventricle.
Put it up. I have computer. Okay. So
what we were picking up.
You're very right. That's
because
why
we were seeing less P waves because it were hidden by RV. So it was very difficult for us at our level to pick.
So there is nothing like our level. You are as accomplished as anybody else. But what we all need is that little confidence in our eyes and mind that no, let me look more carefully. If you look more carefully,
let me complete. So what I was seeing, let us not include we all. What I was seeing, the PR interval was increasingly decreasing. So I was categorizing that in that heart block, second degree or that where PR interval goes on decreasing and that level. So reaching that level of complete heart block, I had different picture in my mind. So how to pick up that hidden P wave? Is there some easy method?
Yeah. So whenever you want to pick up the P wave, as I said, always look carefully, spend a little extra time on the T wave. I showed you at the beginning of the ECG, the T wave, and at the end of the ECG, the T wave. The T wave morphology is not supposed to change because it represents ventricular repolarization. When the T wave morphology changes, that means something is hidden within it. Look carefully, you will see a bump. Sometimes there is a simple 2:1 AV block. We look very carefully. We pay a lot of attention and diligence to T wave. What is happening to the T wave? T wave brings out a lot of it. So I think it was just that you were right, that's why the ECG was put in here, because it should be a complex ECG to understand. So you have to spend a few more moments. Second thing I'd like to share is whenever you're looking at a second degree AV block, or as we call Mobitz type 1 AV block, Wenckebach AV block, what happens there, that in every other beat, the PR interval increments. It's a little complicated there. It's incremental decrement, but then what's happening is for all of us, the PR interval should be increasing before a drop P. But in this case, the PR interval was decreasing. That's why you should look even more carefully. What is it I'm dealing with?
Thank you very much, Dr. Aparna. Please give her a big hand. We would like to hear you again on this forum. You have really done very well, but especially in the basics. Thank you very much.
Thank you so much.
Thank you, Dr. Aparna. She was initially very apprehensive about attendance. So I must say there was more than 100 physical presence and more than 50 in the Zoom. So it has been quite a good attendance. So I request the chairpersons to honor Dr. Aparna Jaswal with a token of appreciation. And it is on the. Now I request Dr. Jagdeep Chub. He's a senior consultant in Fortis in medicine to conduct the session further. Dr. Chub, please.
Thank you, Dr. Jha. I welcome you again on behalf of NDPF. From ECG workshop, now we move to our second workshop, that is Insulin Workshop, and the moderator is Dr. Saket Kant. And the chairperson for this session is Dr. Richa Dewan. I request them to come on the stage. Dr. Richa Dewan is retired director and professor of medicine from Maulana Azad Medical College. And presently she is senior consultant medicine at Sir Ganga Ram Hospital. Our second chairperson is Dr. Monish Sahu. He is at Wim Hans. Third, I request all of them to please come on the stage. Next in is Dr. Deep Dutt. He is running his CEDAR clinic. He's an endocrinologist. And next is Dr. Ghanshyam Pangte. He is Professor Medicine, Lady Hardinge Medical College. And I request Dr. Rajesh Khadgawat, Professor in Endocrinologist, to please come on the stage. I request Dr. Richard Dewan to introduce Dr. Saket Khan, please.
Hello, person requested to chairperson, moderator and speaker. Kindly stick to the time. Time is short, please. Kindly wind up within the time, allotted time.
There's no introduction paper here, but anyway. Yeah. Good morning, everyone. Welcome to this session on insulins. It's a workshop, basically. And for this, I have a moderator, Dr. Saket Kant, who's a senior consultant endocrinologist at Max Shalimar. And he has changed slightly the format of this workshop in a way that it's not the lecture-based workshop. It's more like a panelist with some questions which he will raise. And in the end, the session will be summed up by Dr. Rajesh Khadgawat, who is Professor of Endocrinology at All India Institute. So I welcome Dr. Saket Khan to start the proceedings.
Right, thank you very much for that kind introduction. So what I'll be doing is taking you quickly through the insulin symposium discussion with the panelists, and we can take the questions in the last. I would request all the panelists to be crisp and precise with the answer so that we can finish on time. So I would start with Dr. Mona Shesh because a lot of postgraduate students would be attending this symposium. What would be your ideal time to initiate insulin in patients with type 2 diabetes, early insulin therapy versus late? And when would you start insulin therapy for your patients?
So since it's a pointed question, when do I do that? Mostly we say that the best time to plant a tree was 20 years ago and the second best is now. So perhaps a lot of patients essentially need insulin. What I do is in context with type 2 diabetes mellitus, if there's also associated with any catabolic state, there's an instinctive choice of insulin, number one. Number two, with the pure mathematical aspects, if there's a type 2 diabetes mellitus, with an HbA1c, let's say around more than 9%, and a failure to one therapy, that is a primary therapy of metformin, insulin comes also as a choice as a part of algorithm. What I essentially do as a part of practice is, if a patient with type 2 diabetes mellitus with at least 2 oral therapies, still not getting adequate control, therefore a persistent hyperglycemia, merits a choice and a therapy of insulin without any other delay. Otherwise, it is actually essentially as a part of our own clinical inertia. So that's my message and the first answer to the question. Thank you.
So coming to Dr. Deep, a lot of patients would have apprehensions regarding starting insulin because they will think end of the road for them, probably the disease is too advanced. So how do you counsel your patients regarding initiation of insulin therapy or any injectable in that case?
Are a lot of myths and misconceptions about insulin. So I start off being proactive. I tell myself before there's anything, so I know what doubts you have. Insulin is not addictive. It's not habit forming. It's life saving. I give the example of COVID pandemic, how insulin saved so many people with uncontrolled diabetes at that point of time. And another big fear is they have the fear of needle pain, of needle prick phobia. So that I address by telling them, please get your insulin pen and needle now. I'm waiting for you. And please take the first shot in front of me. Once they take the first shot in front of me, all their fears just melt away.
Dr. Ghanshyam, patients have a lot of myths regarding insulin. Injectable therapy would be painful. They will be dependent on for life on insulin, the risk of hypoglycemia, the risk of weight gain. So how much of this is true and how would you be counseling your patients regarding insulin therapy?
Yeah, like Dr. Deep has already said, the most important myth and the complaint that patient comes when you plan to start him on insulin is मुझे आदत तो नहीं पड़ जाएगी इस injection की. So they are feared of कि they don't want to take insulin. So most important is counseling. So we have to sit with the patient and give appropriate time to them that now a good amount of technology has come up. The insulin needles has gone so fine that it's almost painless and nothing like dependent. आदत पड़ने की कोई ऐसी कोई problem नहीं है. Once their sugars are controlled, they can be weaned off from the insulin, especially type 2, and also with exercise and lifestyle modification, which is must for all diabetes patient. We can wean off these patients from insulin, especially early diabetes and patient who are requiring low dose of insulin. So main important thing is counseling.
Dr. Monashish, a lot of physicians also have clinical inertia regarding starting insulin. So what would you recommend the physicians, how early? Because we see that patients are having A1C of 10 for a very long time. They are reluctant to start insulin. Even the physician is reluctant to start insulin because they need time to start insulin, to explain how to take insulin, storage, as also hypoglycemia.
So, of course, as an inertia, it could be clinical based, clinician based, or a kind of from a patient context. Let me say, even why do I have also an inertia sometimes in advising and advocating insulin? I believe there's something which is not simple or something which is very complex will always be very, very difficult to follow from the part of patients. So that inertia is that from my side also, as to if I advise, am I making the regimen very simpler for my patient? And so the first thing is, how do I take care of my inertia of not complicating the regimen? And therefore, how do I break that inertia even in my own mind is essentially to think about a regimen which is very, very simple, something for the patient to take it on and be in charge of things. And therefore comes as an instinctive, again, a choice of like a basal insulin. The second inertia is that even from my head as well, that if I'm seeing a patient and I have a kind of a consultation aspect, when I see this, I equally mean that it's not just about you, it is equally about me. Is that if I'm writing an insulin over that 15 minutes of a consultation with the patient, how am I going to take care of this hypoglycemia aspect? So that's the second inertia in my mind, which I'm pretty sure is also in your mind. And therefore, again, simplifying a regimen which has got a lesser chances of hypoglycemia and as a beginning, as an initial part of an insulin. The third, again, as an inertia, which is also in my mind as a physician, is that what's about the weight gain? The moment it is in terms of an insulin, and I've struggled so hard with my patients to bring down the weight with an advent of the choice of therapies. And just because of the sugar-centric perspective, the glucocentricity perspective, I'm now advocating an insulin, which I know would not be weight neutral. It certainly would be weight gain. But breaking the inertia means that I have to invest my time as a part of counseling and B, to take help of somebody who can educate the patient, whether it is a diabetes educator who is trained or anybody even from an office staff. We are not talking about somebody who is educating them on insulin injection technique. Somebody who can talk to them, and we have trained some of our own office staff to do that hand holding and talk about that. Don't worry on the hypoglycemia. There are many other patients who are also taking care of it. Don't worry about the weight gain, ma'am or sir. We are taking care of the lifestyle intervention, etc. And the other last inertia is that in terms of the cost, adding a cost of therapy. I mean, all said and done, at the end of the day, we all are emotional people. So again, choosing some regimen which is not so very costly is how I break my own inertia. On that note, thank you.
Dr. Deep, you already answered that question. Injecting insulin, some practical tips. Always get the patient with the needle and the pen to your clinic, inject the first dose in front of you. So I probably would skip that question. I'll come to Dr. Ghanshyam. Whenever you plan to initiate insulin for your patients, what factors would you consider? What insulin you want to give to your patient? What are the factors that you would be considering?
Yeah, Dr. Saket, as I work in a public sector government setup, so most important, the patient which are coming to us are very poor. So first and foremost, I see the cost. Although we do provide insulin, regular insulin and NPH insulin from the clinic, but for 10 to 15 days, and that is also used nearby patients only. So cost is the most important thing, that is the patient will be able to afford the insulin, especially the new analogs one which are coming, and also education. The second is education, how educated the patient is. So will he or she will be able to get the insulin appropriate dosing, or is there any caregiver who can take care of those insulin injection? Because hypoglycemia once it happens to a patient, it scares the patient, and a lot of patients do not go again to again insulin. Third is storage. So storage is another problem. In a poor setting, we still needs a refrigerator to store those insulin. So even if the patient is poor, we do ask if there's any close neighbors are there who can store their insulin so that it doesn't get spoiled. And other thing is hand-eye coordination. That a lot of elderly patient will have retinopathy and all. So will they be able to see the loading, how much dose is given? So all these things, but cost, education, and storage is the premier one I usually see when I initiate a patient on insulin.
Dr. Monash, you've got a lot of options starting insulin, basal, basal plus, basal bolus, premixes. A lot of premixes also available. So what would be you'll have to individualize your regimens according to the patient, but how do you choose between these regimens when you plan to start your therapies?
So since the question is how do I start a therapy, is since it's a part of an initiation, with an adage of please simplify all the regimen, the choice, and I use this word very often, instinctive choice comes as a basal insulin, because that makes our job so easier. Start with the basal at any point of the day, look at the fasting blood glucose the next subsequent days, and maybe after every third or the fourth day, if you're still not attaining a target, keep on titrating the dose. So once we initiate, is the most simple thing which we can educate over 2 minutes. Patient could we keep on reinforcing it. So it simplifies the regimen. That does not take away the choice of other premixed insulin in a very few subset of patients whom I know they may not be coming after so frequently. And I know that just with a basal insulin, let's say an HbA1c is coming at around 11%, and he or she is already on a kind of a full dose of sulfonylurea. And with the cost, as to Dr. Ghanshyam, as you stated, I mean, since this is a very, very low cost therapy of a premixed insulin, it's also a kind of a very wise choice to use some insulin just to ensure that there is no hyperglycemia. Patient doesn't get into this kind of a typical catabolic state. So it also comes as a choice. But by and large, my major and the first forward choice is basal insulin without any doubt, to simplify the regimen.
Dr. Deep, you have guidelines suggesting insulin therapy after 3 OADs. But now, because we are moving away from a glycemia-based approach to a more pathophysiology-based holistic approach, and you've got a lot of drugs that can target more parts of the pathophysiology, what is your take on initiating insulin after how many OADs would you be preferring to start insulin therapy?
Because the practice generally the practice differs from what the guidelines say. Many times we see patients who are already on maybe even 4 or 5 OADs and not having a good control. So with the advent of newer agents like SGLT2 inhibitors, which have so-called insulin independent mechanism of action, starting them at HbA1c of more than 9 increases the risk of euglycemic ketosis. Again, the quantum of glycosuria would be greater, and they would again have a higher risk of genital infection simply because of the glycemic load which would be coming out of the urine. That's a very dangerous practice to do and should not be done. I think insulin gels in very well with all the OADs. I think the dictum of sticking with 3 OADs and not doing well and starting insulin is a very rational and practical option which we should stick to. And as Dr. Monash said, we simply start with 1 prick per day. It may be a basal insulin or a premixed insulin. A lot of factors come into it. Cost also comes into it. So, but really makes the life easier. That reduces the glycemic variability, and sticking to like keeping 2 secretagogues away from the same meal. So if you're using a secretagogue, give it in a separate meal, give insulin in the other meal. This is something which has to be kept in mind.
Now, coming to Dr. Ghanshyam, so a lot of patients and a lot of physicians also have this question. You're starting insulin for your patient. If it is a basal insulin, you can safely continue your secretagogues and glinides. But if you're initiating a basal bolus or a premixed insulin, what would be your advice on the status of sulfonylurea and glinides?
Many of our patients are on like sulfonylurea, especially glinides and all, because of affordability issues. So they do continue, and when their sugars are uncontrolled with additional metformin, most of them are there. So we do start insulin, but chances of hypoglycemias are very high with starting insulin plus sulfonylurea. Secondly, if you see physiology, these are insulin secretagogues. So physiological also those two, there's a second school of thought or a controversy that they should not be combined. But in Indian setting, we do see that sugar controls are better if we combine this thing. But we should monitor these patients regularly, and patients who are elderly and who has previous episode of hypoglycemias and all, There, either we should reduce the dose of sulfonylurea to reduce the chances of hypoglycemia, and regular monitoring should be there for blood sugar monitoring by SMBG.
Dr. Monashish, you favored basal insulin as the therapy of choice. A lot of, if you look at the drug inserts of basal insulin, they would say that it has to be weight and glycemia based. So that can be to the tune of, sometimes they suggest that you have to give around 25 to 30 units depending on weight and glycemia. Do you agree it is more practical, or you do something else? You do not start weight and glycemia based therapy for basal insulin, you do something else and up titrate slowly.
So what I do is that we typically start it and up titrate it slowly. As I said, that the first thing is that one, simplifying, and the second important thing is that the inertia in both our mind as well as the patient mind is to ensure whatever we do to prevent a hypoglycemia, without any doubt. Because it's the hypoglycemia that always robs the confidence. Ki, "Sir, doctor saab ye kya de diya?" There's the first step that needs to be covered up, and therefore we typically start slowly. And the general recommendation is that it's a weight based, so something like around 0.2 units per kg, like let's say it's around 60 kg, so it goes up to around 12 units. But that is also overridden in terms of an art of clinical practice. If I'm seeing an HbA1c of around, let's say 11% or 12%, somebody whom I'm seeing is very obvious by the clinical features as an insulin resistance. We know that this is not going to work, and just a kind of such a conservative approach of 12 units will do no harm, will do no good, because that robs the confidence ki ye chota sa insulin chala liya, tab bhi then also the glucose is not controlled, and then we go on to a slightly higher dose. So the question is about the starting dose and not the end dose. So the starting dose, we typically start on a very, very slow dose, like either a 0.2 units per kg or even an arbitrary dose which has been used as a part of clinical trials, like start with 12 units and up titrate it every alternate day or every third day. Is it glycemia based? Yes, as I said, that looking at the HbA1c, if I know that it's the 0.2 units per kg, just a meager 12 units is not going to work, go up at a higher dose.
Coming to Dr. Deep, so titration of basal insulins, a lot of recommendations, 1 unit per day, 2 units every 3 days. But do you think it is more practical to titrate on the basis of T-half of the insulin that you're giving?
It depends again what insulin we are using. So if you're using an NPH based premixed insulin, which is not a truly basal, it's intermediate insulin, I think they need more close monitoring. We don't have the flexibility of giving it in afternoon and expecting it to control the morning. So if you're giving an NPH based premixed insulin, you have to cover the dinner strictly to have some good reasonable impact on the fasting blood glucose control. If you are starting with glargine insulin, I think again it has a reasonably around 20 hours of T half-life. Again, we typically give it in the night. We give it typically after the meal at around 10 p.m. in the night. If patient really wants more comfort, some people prefer taking it pre-meals, so you can give it pre-meals also. If you go to the ultra long acting basal insulins like maybe U300 glargine or degludec insulin, you have more flexibility. Some people are really worried, especially elderly, ki raat mein insulin nahi lagayenge, subah lo gaya. They can take this ultra long acting basal insulin even in the morning or afternoon, and you can still have a very good control of the next day fasting blood glucose.
Dr. Kancham, got a lot of basal insulins. You've got glargine, U100, U300, degludec. What would be your choice if cost is not an issue? And if cost is an issue, what would be your choice of a basal insulin?
Basal insulin, I think the longest of all three is degludec. Although again you said cost is not an issue, then I will prefer degludec, and its half-life is around like its action lasts for 40 hours. So I will prefer degludec over other two if cost is not the issue.
Do you think titration would be somewhat difficult with degludec as compared to giving U100 glargine because of the longer half-life? The titrations have to be slower with degludec as compared to glargine?
Yeah, theoretically, that is true that titration will be slightly longer time, but practically I have not used much of our degludec. I will request Dr. Rajesh to share his experience on degludec if he can.
So the difference between degludec and previously available basal insulin glargine is hardly not very clinically significant. However, pharmacologically there is a longer half-life, and in clinical trial it has been shown that associated with the better HbA1c if we head-to-head trial they use with glargine. So that's one point. But if we compare the cost of degludec, which is much higher in comparison to the basal insulin glargine, as well as if cost is almost non-comparable if we use NPH as basal insulin. So what we are getting, we are not giving insulin for a week or 10 days. We are giving insulin for a longer period, maybe years together. And this small cost in per day will make a big difference. If cost is not a problem, theoretically, degludec is a better option than the other basal insulin.
Coming to Dr. Monashesh, you have a patient on basal plus insulin, not controlled. You want the better control. Would you like to shift the patient to a basal bolus regimen, or you like to shift the patient to a simpler premixed insulin with some higher degree of risk of hypoglycemia?
So a basal plus means giving a basal and just one prandial insulin. And the question is that from a basal plus, if the sugars are still not controlled, what's my preference? Without any doubt, it's a basal bolus, because that's the only thing from from a theoretical perspective, and B, from an ease of ensuring no hypoglycemia, no late postprandial hypoglycemia, is a basal bolus. Yes, it will be 4 pricks in a day. As compared to a premixed. However, it has been very well established with the concept of a basal bolus versus a premixed. The rate of hypoglycemia, without any doubt, in a premixed is a higher pedestal as compared to basal bolus. So, but the fact is that basal bolus sometimes can be a bit complicated for the patient to follow. And if through the so-called journey with the patient's care, if we feel that it is getting complicated, if not in a rare fashion, but we do advocate even a premixed insulin, only ensuring and keep on repeating that please eat on time, otherwise you run the risk of hypoglycemia.
Coming to Dr. Deep, a lot of our Indian guidelines also suggest that you can give premixed insulin 3 times a day. So what would be your comment giving premixed insulin 3 times a day, having 6 peaks versus giving a rapid in the morning, a rapid in the afternoon, and a basal bolus or a basal plus in the evening, 3 injections, both of them have 3 injections. Premix 3 times a day versus a rapid, and a basal bolus in the evening. What would be your preference for this?
Yeah, so great question, difficult one to answer. No clear cut yes and no, lot of gray areas here to start with. So yes, basal bolus gold standard. You have a nice glargine based basal insulin, which is the backbone of basal insulin, 3 times short acting. Even a simple regular human insulin does a great job. You may not use a ultra short acting analog every time it's not needed. That's the benchmark, no doubt. Dr. Monashesh just highlighted. But in reality, practicality is a lot of different. We are talking of type 2 diabetes here, not type 1 diabetes. As Dr. Sahu just said, working people, they don't like carrying insulin to office. There's a lot of social stigma, phobia. My boss will see I'm taking insulin, my CR might be affected. So they say कि घर से लगा के जाएंगे और रात में लगाएंगे. So we are forced to give premixed insulin twice a day. We are comfortable giving premixed insulin twice a day and a secretagogue in the afternoon. And don't miss the meals, because the insulin doesn't know that you're going to miss your meal. You're going to have a risk of hypo. Same thing I repeat to my patients, give it in writing. Now coming to premixed insulin thrice a day. Yes, we have data, a lot of published papers to show the data shows that glycemic control is as good as giving basal bolus regimen, but again, the risk of hypos is much more. So in a really persistent patient with the HbA1c of more than 9 already on twice a day premixed insulin, I am not able to convince him to take 4 pricks a day of basal bolus as a last resort, as a trade-off. Okay, abhi 2 mahina try kar lete premix twice a day, baad mein to jana hi padega basal bolus. That is what I do in my practice.
All right, so you have clinical inertia in starting insulin, up titration also you have inertia. So you have to have self-monitoring blood glucose. Dr. Ghanshyam, what would be your suggestion to your patients on various regimens? How many times do they prick themselves, self-monitoring of blood glucose?
Self-monitoring of blood glucose is very important in diabetes patient. And the recommendation is at least 4 times blood sugar monitoring should be done in patients who are on insulin. And maybe 6 times patient who has been recently changed, whose dose has been recently changed. So 4 times means at least 3 times before meal, including 1 fasting, and 1 bedtime insulin. Sugar monitoring should be done. While whenever there's a change in routine, there's a change in meal and all, so their postprandial sugar can be added on. While patients who are not on insulin, they can have more infrequent, maybe once in a week, sugars can be done to reinforce that they need more frequent monitoring of diabetes.
Dr. Monashesh, you've got a lot of premixed insulins, 25, 75, 30, 70, 50, 50. Where do they fit in your patients? And do you routinely give a 30, 70 in the morning, a 50, 50 in the evening to some of your patients with a high carbohydrate content in the evening? Or you would prefer to give both doses to be the same?
Luckily, it's so convenient nowadays to choose with a wide range of options. 25/75 and a 30/70 by and large are similar to each other. The difference is in terms of how about this 25/75 or 30/70 versus a 50/50, the logical choices that the 50/50, I use it as to if there is a kind of a greater burden of a post-meal hyperglycemia as opposed to a pre-meal, thank you, as opposed to a pre-meal hyperglycemia. Now, so that's how I choose among my clinical practice.
The cost benefit analysis, Dr. Deep, because we see a lot of patients of various economic strata. So regular versus analog and cartridge and syringe versus pens. How do you decide which patient is fit for which one?
So very important question, not discussed commonly. I think the costs are important. As a rule of thumb, if you see, if you're talking of, I preferably use a cartridge and a pen because the ultra fine needles really is a totally painless experience. If you talk of cartridge, the lowest one, even if you're talking of a 30/70 premixed, the cost comes to around 0.9 to 1 rupee per unit. So if a person is taking average 30 units per day, he's spending 30 rupees. If he straightly moves over to an analog based premixed insulin, the cost per unit directly goes up to around 2.5 to 3 rupees per unit. So if a person taking 30 units of analog based premixed insulin, he's spending around 70 to 90 rupees per day. That's even costlier than the costliest SGLT2 inhibitors. That's a lot of money. And the moment he goes to the ultra long acting basal insulin, that comes around 5.5 to 6 rupees per unit. So that's, you can see, calculated 150 to 180 rupees per, that's a lot of money to spend out of pocket for average Indian also. So as a rule, I use premixed insulin, the normal premixed insulin, no analogs. In a pen, comes to around 0.9 to 1 units per day. In a really non-affording patient, I go over to a syringe and a vial. There the cost of per unit comes down to as low as 0.5 rupees per unit. So we can bring down the cost of therapy to around maybe 15 rupees per day.
In syringes, you have to be very careful whether the patient is taking a 40 IU insulin or 100 IU insulin, that you have to counsel. So because a lot of patients we've seen insulin 100 IU, they're taking it from the cartridge and they're injecting with 40 IU syringes. So that we have to be very careful. What is your comments, Dr. Ghanshyam? A lot of needles that you have available. So because the finer the needle gets, the less is the pain. So what are your comments, and which patient would you prefer to give a finer needle for injecting insulin?
Like syringes, you said there's a two types of syringes available in India. Like one is red capped and another is orange. The red capped is 40 IU per ml. Another is 100 IU per ml is the orange cap. So if we intermingle these two needles, because the potency changes up to 2.5 times with these changes. So we should be very cautious how many IU of insulin vial we are using and how many IU of syringe we are using. Both should be same. Regarding the size of the needle and fine, I think finer the needle, less the pain, although cost will be increasing with that. So 4 mm needle will be the appropriate one, especially in thin build patient, so that there's no inadvertent injection to the intramuscular injection, and that cause a rapid insulin dosing and hypoglycemia. So thinner the needle, better the experience, minus the cost. While syringes, especially in a poor setting, those red and orange cap syringes should be taken care of.
Coming to diabetes and technology, final two questions to Dr. Monashish and Dr. Deep Datta. Insulin pumps, the types, and who would be an ideal candidate for an insulin pump in your practice?
So I hope this question is not about type 1. For sure, the type 1 is almost everybody, regardless of age, may get the benefit of insulin pump is most of the recommendation. So the trick part of the question is, what about in type 2 diabetes? In the setting of type 2 diabetes mellitus, the data is not very clear. It does not support the role of an insulin pump. Now, however, some of the studies have suggested in the setting of a persistent hyperglycemia with an unpredictable glycemic pattern, defined as a hypoglycemia, or where we are expecting an unpredictable absorption related to the subcutaneous insulin depot, perhaps there may be a benefit of insulin pump, with an advantage that insulin pump keeps on delivering with mini boluses all throughout the day. So the reduction of the size of the subcutaneous depot of insulin via the insulin pump may lead to a predictable insulin absorption. Now coming over to this ideal candidate, therefore, in a type 2 diabetes mellitus with persistent hyperglycemia with an unpredictable glycemic pattern despite on a multiple daily dose of insulin, that is 4 times insulin. What about the types? Broadly 2 types. One is the conventional type where we set manually the insulin rate of a basal with a varying basal and a bolus. And then there's something called as a sensor augmented insulin pump. That means there's a sensor which monitors the glucose, it feeds that a pump, and the pump can calculate or can help calculate it. There's also in the sensor augmented something called as a hybrid, just like that hybrid cars. It can run on the petrol as well as it can run on the electricity. So the hybrid pump means that there is something which it can set it, but still the bolus has to be set manually. So that's the hybrid one. So broadly 2. One is the conventional in which everything has to be set, which is by far the commonest available. And the second is a sensor augmented pump.
And then now that you have the bionic pancreas also with insulin suspend technology and glucagon infusions, probably the pumps are getting safer, but they're getting costlier. With that final word, I probably hand it over to Dr. Rajesh Kadgapat for the final comments.
Thank you, Dr. Saket. I think we have touched upon and discussed all the practical points which are needed for starting insulin therapy and continuing in, especially in type 2 diabetes patient. We know that type 1, we do not have much option. Just to summarize that adequate doses of oral hypoglycemic agents for a good amount of period should be given before taking a decision the patient is having secondary OHA failure or any other requirement of insulin. So even if we use more than 50% of approved dose for at least 2 to 3 weeks before labeling a OHA failure or person is not responding to oral hypoglycemic agent. And most of the time we believe that it's a last therapy. This is not the last therapy. Nowadays we are shifting to a concept where we start insulin as early as possible, and it may also be possible that we give insulin for some time, and once glycemic control is achieved, so we can stop that. Only thing we wanted to discuss here today is our concept about glycemic control in conventional insulin vis-a-vis in insulin analogs. So till now, majority of studies have not shown any difference if we use conventional insulin, that is regular or intermediate acting insulin, which we are using from years together, or if we use newer insulin analog, which are much costlier. Dr. Deep has given some rough idea about that. Regular insulin cost 0.4 rupees or 40 paise per unit, while newer insulin analogs cost 2.4 rupees per unit. So it's a 2 rupees difference on the cost, and if somebody is using 30 units, so there is 60 rupees difference per day, which may escalate to larger amount of cost if we use for longer period. So glycemic status wise, there is absolutely no difference between conventional insulin versus analog. Only difference comes in incidence of hypoglycemia, which is significantly more with the conventional insulin than insulin analog. And regarding oral hypoglycemic starting oral hypoglycemic agents in these patients, we know, we have discussed that any of these oral hypoglycemic agent can be combined with the insulin, especially the basal insulin, as panelists has favored that basal insulin is very convenient to start. However, our last point would like to highlight is conventional insulin, which we are using from years, is not outdated, gives adequately same glycemic control if used in proper doses, but it gives a great financial benefit to our patients.
Thank you very much.
Sir, I would like to highlight a point. A big thanks to Dr. Saket for joining us. His father is in hospital admitted for 3 days and he's coming from hospital directly. So big applause for Dr. Saket.
Thank you for closing the session for me. Thank you very much. It was a very nice session, Dr. Saket. We moderated so well. Almost all the points were well covered, though it's a very vast subject. And I'm sure there'll be questions. And I tell all the people in audience to talk to the speakers later on during the lunch or tea time. And thank you very much. I thank all my panelists for this wonderful session. Thank you, Dr. Rajesh, for summing up so well, bringing up all the important points. Thank you once again.
Thank you, Dr. Saket Khan, and all the panelists and chairpersons for the wonderful section. I request them to collect their memento on the stage, which is on my right side. Now, for the next session, I invite Dr. Mukesh Bhatia, the quiz master. And for this session, the chairpersons are Dr. Sunil Khetrapal. He is the senior most physician in this area. Dr. Rajiv Diwan, he is senior consultant at Saroj Hospital. Dr. Rajiv Arora. Dr. Rajiv Arora is senior consultant, Maharaja Agrasen Hospital, Ashok Vihar. And Dr. NN Jha. Dr. Jha is, everybody knows, is the senior most consultant at Fortis Hospital. I request them all to come over here and take their chair. I request them to introduce Dr. Bhatia, please.
Dr. Bhatia was the first person to start coaching for admission in MDs. Now at present, he is a director of Bhatia Medical Institute for the postgraduate entrance for DM, MRCP, and USMLE. He has got physical as well as online classes all over the country, even abroad. And then I request Dr. Bhatia to start his presentation.
Thank you, Dr. Khetrapal, for the kind introduction. Well, it's a quiz. Everybody has to take part. I already have shared this question in the app. I think all the residents have done the questions. Well, so let's discuss. This type of hand are seen in which condition? Option A, diabetes, pseudo-hypoparathyroid, Cushing syndrome, and acromegaly. Well, the answer of this question is pseudo-hypoparathyroid. You can see the hand of pseudo-hypoparathyroid, characteristic shortening of fourth and fifth metacarpals. Okay. Now, extra learning point about this question. Knuckle dimple signs. What is this? If we close our wrists, we can see there are knuckles. This is normal. Knuckle, 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 knuckle. In Down syndrome, we have a knuckle, 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 but the third, this is dimple. So Down syndrome, short third metacarpal bone, and this is known as knuckle, dimple, knuckle, knuckle sign. In Turner syndrome, dimpling is in the fourth. And in pseudo-hypoparathyroid, dimple is in the fourth and fifth. This is knuckle, knuckle, dimple, knuckle, 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 dimple, and dimple sign. So they are the important point that you should remember. Next question. A clinical test was done JVP, hypertension, and prominent carotid pulsation. You can see this gentleman, and now he is raising the hand, and you can see that the color has totally changed. It's an important clue. Well, the right answer of this question is non-pulsatile raised JVP. But what is this? What is the name of this test? Pemberton sign. It is seen in which condition? Superior vena cava syndrome, or so-called superior vena cava obstruction. Most common cause of SP, superior vena cava obstruction, is lung cancer. Again, I'll go back to the slide. Now you can make out classically change of color. So classical, if you are getting non-pulsatile raised JVP, this is the diagnostic. There is no other condition where we have this sign seen non-pulsatile JVP. An additional finding, prominent upper body veins, they are the classical finding that we see in associated finding in such cases. Question 3. Which of the following is the most specific sign for grave disease? Upper lid retraction, lid lag, wide staring gaze, and chemosis. So now I request all the resident doctors to answer this question. It's not for the senior consultant, which are my teachers. So I have no right to ask question to you. Every resident doctor will answer this question. Raise the hand. Who says answer is A? Who says B? C? D? Well, the right answer is D, chemosis. Why this? Let's learn the basic concept. We have three terms: thyrotoxicosis, hyperthyroid, grave disease. They're all different. They are not same. Let us learn the basic concept. Thyrotoxicosis, any condition where the thyroid hormone level is high, is thyrotoxicosis. The source of hormone can be thyroid, what we call as hyperthyroid. It can be extra thyroid, then we call it euthyroid. The source of extra thyroid are stoma ovari, factitious thyrotoxicosis, dequirins thyrotoxicosis. Then hyperthyroid grave disease, toxic adenoma or multinodular goiter. Grave disease itself is hyperthyroid, ophthalmopathy, dermopathy is an autoimmune disorder. This is a basic concept that the three terms, they're all different. Now, one more thing. Thyroid hormone increases the sensitivity of beta receptor to epinephrine. That's why there are a lot of things common between feature of hyperthyroid and pheochromocytoma. Now, we have a muscle called levator cup palpebris superior and Muller muscle. This red color is Muller muscle, which is there in the upper eyelid. This is a unique muscle in the body, which has got is a somatic muscle, but it has got sympathetic supply. So, following eye signs are seen in all cases of thyrotoxicosis because they are feature of due to sympathetic overstimulation causing Muller muscle contraction. So, white tearing jays, upper lid retraction, lid lag, decreased blinking, they are seen in all cases of thyrotoxicosis. But eye signs which are seen only in grave disease, remember it's an autoimmune disorder, chemosis, proptosis, diplopia, peptidema, they are seen in grave disease. Okay. So this is lid retraction. This is lid lag with down gaze. This is proptosis bulging. This is seen in grave disease. And we have chemosis. Red, this is again seen in grave disease. So I hope you are clear about, although time is very less, I have to finish in 30 minutes. So at least I can give an overall view. Now, next question. Which of the following is the most accurate test to diagnose subarachnoid hemorrhage? Non-contrast CT, contrast CT, MRI, and lumbar puncture. Again, question only for the resident doctor who says A, B, C, D. Well, it's a beautiful question. Most of people have gone for this answer. This is the most common wrong answer. Answer is D. Why D? Why not A? Well, investigation of subarachnoid hemorrhage. What is the classical finding? Sudden onset of headache, never experienced before. This, you get this line. This is subarachnoid hemorrhage. Best initial test is non-contrast CT scan. It's an investigation choice, but sensitivity is 95%. So if the question is, which is the best initial investigation, non-contrast CT. But question here is, which is the most accurate test? Most accurate test is lumbar puncture. And now what we get in CT scan, you get blood is filling in the subarachnoid cistern. Okay, you can see the blood is there. Now, most accurate is CSF finding. Hallmark is blood in CSF. And after 6 to 8 hours, these lysis of RBC occur and subsequent conversion of hemoglobin to bilirubin stain the spinal fluid yellow. And this is so-called xanthochromic CSF. So the most accurate test is lumbar puncture. This is subdural hematoma, CT scan. And this is the classical extradural hematoma by convex finding that we get. Next question. This is seen in which condition? You can see the eye, tuberous sclerosis, neurofibromatosis, von Hippel-Lindau, and Sturge-Weber syndrome. Well, it's a beautiful picture. Answer is neurofibromatosis 1. It's a lesion nodule, pigmented hematomas. What are the other findings that we see in NF1, extra learning point? Caffeolate spot. This is the one thing, ये कभी नहीं भूलना है. Whenever they talk about NF1, ये नाम जरूर आता है. Axillary freckling, so-called crow sign. This is neurofibroma. This is one of the virtually diagnostic for NF1. One of the diagnostic feature. Optic glioma is a finding, a cancer common in this, and we have meningiomas common associated with NF1. Well, in NF2, we get subcapsular cataract, and this is the one, don't forget. Whenever they talk about NF2, they will always talk about schwannoma. Von Hippel-Lindau syndrome, we get hemangioblastoma. That's the lead to polycythemia. Don't forget this line. This is the prize-winning question. In tuberous sclerosis, we get shagreen patch. This is ash leaf spot we get in tuberous sclerosis. Adenoma sebaceum, again, tuberous sclerosis. This is hydrocephalus, tuberous sclerosis. And subependymal giant cell astrocytoma. One of the classical findings that we get, of course, this is more in children. Sturge-Weber syndrome, port wine stain. So this is in brief about the neurocutaneous syndrome. Remember, all neurocutaneous syndrome are autosomal dominant, except this one. This can be sporadic, and this is the only one which is not associated with any cancer. Well, question 6. A 32-year lady complained of vision problem. This is the problem. Problem started about 5 days back. 3 years back, she had right hemiplegia, but she recovered with treatment. Your diagnosis? Acute congestive glaucoma, hypertensive retinopathy, then multiple sclerosis and pituitary adenoma. Well, you can see clear picture, and this is so-called washout picture. This is seen in multiple sclerosis due to optic neuritis. Okay, this is just see faded color appearance. Extra finding, extra learning point about MS, you get MRI. How we diagnose optic neuritis? You do MRI. And extra learning point in MS, you get relative afferent pupillary defect, Marcus gun pupil. Demyelinating plaque are the classicals. Remember, in MRI, so they ask question, what the first investigation in MS, MRI. Second question, what the most accurate test is again MRI. So MRI, we get demyelinating plaque, so-called Dawson finger sign, periventricular plaques we are getting. Well, internuclear ophthalmoplegia is virtually one of the diagnostic feature of multiple sclerosis. Next question. This type of tongue is seen in which condition? Hypothyroid, pernicious anemia, myasthenia gravis, and iron deficiency anemia. Well, if you look into this, you are getting 1 furrow, 2 furrow, 3 furrow. So this is myasthenia gravis. So triple furrow tongue is seen in myasthenia gravis, 1, 2, 3. Extra learning point about MS, myasthenia gravis. Evening fatigue and especially binocular diplopia and ptosis are highly characteristic of myasthenia gravis. See the morning eye and see the evening eye, ptosis, clear cut is there. This is one of the virtually diagnostic or characteristic feature of myasthenia gravis. Starling face appearance. This is because ptosis that the frontalis muscle patient uses overactivity of frontalis muscle, that this gives so-called starling face appearance. Then ice pack test. This every resident doctor should know. They're going to ask you this question. How really patient come to you in OPD? How you confirm? You put an ice pack over this, and you can see within few pack test. Simple OPD test. Next question. A young lady complained of proximal muscle weakness and she has skin rash as shown. It is seen in which condition? Myasthenia gravis, hypothyroid, dermatopolymyositis, and grave disease. Well, again, this picture, all resident doctors should remember. This is dermatopolymyositis. So let's learn some extra learning point. Heliotropic rash. This is purple rash, raccoon eyes, what they call as. Shawl sign at the rash at the back. Gotron signs, scaly paprika patches over this, can't afford to miss this slide. This is again mechanic hand, rough hands, and rash, V sign. Over the front is V sign. They're all the classical findings that we see in dermatopolymyositis, which can be associated with internal malignancy also. Any case of dermatopolymyositis should always be investigated for internal malignancies. Well, this is beautiful basic science. The brown graph, this is the normal cardiac action potential, and the blue graph is by a drug, antiarrhythmic drug. Which of the following drug can cause this picture? Well, quinidine, lignocaine, verapamil, or amiodarone. Again, question only for the resident to answer. Who says A, B, C, D? So before we discuss, a little bit brief answer, quinidine hai. Little bit basic concept. This is a normal cardiac cycle action potential. And this is the effective refractory period. If you correlate this electrocardiophysiology with ECG, this is the QT interval. Effective refractory period is equivalent to QT interval. Okay, this background. Now, we have class one drug. Class one drug are sodium channel blocker. How to find out? This is the, look into this. If you are getting shifting this curve, this is class one, which is sodium channel blocking drug. Okay, now look into this. We are getting increased QT interval. This is class 1A drug like quinidine. Look into this. Again, shifting to right side. This is sodium channel blocker class 1. But now the QT interval is short. This is class 1B lignocaine. Now look into this is the shifted to right, but profound. This class 1C. But remember, QT interval is normal. So whenever this curve is shifted to right, this is class 1 drug. Well, now look into this. You are getting prolonged QT interval, but there's no sodium channel blocking drug. No sodium. This is class 1. This is class 3. Example is amiodarone. Okay. Well, drug causing prolonged QT interval, they're all anti-arrhythmic drug, but they themselves can induce arrhythmia. This is known as pro-arrhythmic drug. Class 1A and class 3 are pro-arrhythmic drugs. And although amiodarone is a one drug which causes prolonged QT interval, but still this does not lead to so-called torsade pointes. This is the twisting around the baseline is torsade pointes. This is this was the question in DM entrance exam. Which drug can cause prolonged QT interval but doesn't lead to pro-arrhythmia is amiodarone. Question 10. This endoscopic finding is seen in which condition? Candida, herpes simplex, mentor disease, or scleroderma. Lovely picture, so-called watermelon sign seen in scleroderma. Okay, typical watermelon sign. Now let's have extra learning points. This is celiac disease. Endoscopy finding is scalloped duodenum. Lovely picture. This is Candida esophagitis. White plaque, which are very friable, so-called white pseudomembrane. This is herpes simplex, punch out ulcer. Herpes simplex esophagitis. This is velvety appearance that we see in Barrett's esophagus, also called GERD. This normal esophagus, this velvety for comparative. This is CMV esophagitis, linear ulcers are there. And pill esophagitis, and one very commonly asked question, pill esophagitis, the mid esophagus, not the lower esophagus. Okay, that is caused by so many drugs like non-steroidal anti-inflammatory drugs. Mentor disease, massive gastric folds are seen. Now, this question 11. This barium studies finding are seen in which condition? I think it's a fairly easy question for the resident doctors. Crohn's disease, ulcerative carcinoma colon, and amoebic colitis is a lead pipe appearance. It's in ulcerative colitis is an easy question. Lead pipe appearance, all the folds are disappear. Now, what else? Extra learning point. What else we get in these pseudopolyps? This is a colonoscopic finding. What are the extra articular manifestations that we have in ulcerative colitis? Anterior uveitis, okay, anterior uveitis, erythema nodosum, primary sclerosing cholangitis. You can see this normal bile duct and you can bleeding appearance is seen. In fact, it is written in most of books. If you are getting a case of primary sclerosing cholangitis, never forget to investigate for ulcerative colitis. Well, this is pyoderma gangrenosum. This is X-ray standing position and toxic megacolon. You always look for the transverse colon in the standing position of X abdomen. If this diameter is more than 6 centimeter, that is one of the classical findings that is suggestive of toxic megacolon is an emergency, and because it can rupture, this patient may even need surgery also. Now, this hand deformity is seen in which condition? Again, an easy question: osteoarthritis, rheumatoid, psoriatic, or scleroderma. Well, the answer is rheumatoid arthritis. Let's have extra learning points. This is ulnar deviation of finger. It's one of the classical findings that we get in RA. This is the same X-ray. This is a typical MD exam question. And this is symmetrical arthritis. Whenever they talk about symmetrical arthritis, one of the important findings is always remember is rheumatoid. This is buttonhole deformity, swan neck deformity. This swan neck is buttonhole. This is hammer toe. This is wind sweep deformity. Both the joint are moving to same direction. जैसे हवा आ रही है जो कि दोनों जॉइंट को एक तरफ लेके जा रही है, तो name given is wind sweep deformity. Z deformities. Okay, they're all important deformities. This finding is seen, this CT finding is seen in which condition? Silicosis, asbestosis, berylliosis, and byssinosis. Again, an easy question. This is calcified pleural plaque that we see in asbestosis. And this ferrugation bodies are seen in sputum examination. It is ferruginous, looks like iron. Okay, remember this is not seen in hemosidosis, it's seen in asbestosis. Now in silicosis, extra learning point about pneumoconiosis, eggshell calcification in silicosis. And remember these patients are prone to TB also. This is CT scan, crazy pavement appearance in silicosis. Anthracosis, coal worker disease, if you take the all coal in the lungs, and this is coal macule that we see, coal macule that we see in coal worker disease. This condition can be seen in which of the following conditions? Scleroderma, polyarthritis, SLE, and Behcet syndrome. Question only for resident doctors to answer. Who says A, B, C, D? Well, the answer is polyarthritis nodosa. This is gangrene. Okay. Digital gangrene. Leg. Now, what are the extra points? Extra learning about PAN, leg ulcer. Aneurysm. This is one of the classical exam question. In polyarthritis nodosa, we get aneurysm. You can see aneurysm. And libido reticularis. Now, but Kawasaki disease, which is a disease of children below 5 years, we get coronary artery aneurysm. Okay, this is normal coronary, and you are getting aneurysm in Kawasaki disease. In Kawasaki disease, we also get strawberry tongue. Next question. This type of gums are seen in which condition? Vaginous, henoch-Schönlein, cranial arthritis, or Church-Strauss. Well, you can see this is again strawberry gums that we see in vaginous granulomatosis and strawberry tongue. Remember, we got strawberry tongue in Kawasaki. We are getting strawberry tongue in vaginous. Extra learning point about vaginal. You get nasal septum perforation in vaginous. We get saddle nose and Cienca. If you get this word in your question, this is diagnostic of vaginal. So there's only one condition we have Cienca antibodies. Now, in which of the following condition grade 4 tenderness is seen? rheumatoid, ankylosing spondylitis, gout, and osteoarthritis. Well, the answer is gout. This is podagra. Or tenderness. I have a question for all the resident doctors. Grade 1, tenderness is a sign we elicit. आपने joint को touch किया, pain है तो grade 1. और आपने touch किया, patient cries with pain. This is grade 2. Grade 3, he withdraws. Oh, Dr. Saab, patient will jump. That is grade 3. And grade 4, don't touch, don't touch, don't touch. That is grade 4 tenderness. Well, causes of grade 4 tenderness: septic arthritis, gout, and arthritis in rheumatic fever. Okay, this is again a very important point. In gout, you get stone, external learning point, uric acid crystals. This is tophi in skin. Needle-shaped crystal, virtually diagnostic of gout. And in gout, you get Martel sign, X-ray, overhanging type of bone. Pseudo gout, we get meniscal calcification, is virtually diagnostic of pseudo gout. And finally, you get in shoulder, you get Milwaukee shoulder, we get rice body. These three are so-called crystal deposit disease. 17. This is a peripheral blood film of a 55-year male, massive splenomegaly, what is seen in this picture. Hairy cell leukemia, CLL, AML, or multiple myeloma. Okay. This is hairy cell leukemia. Look into picture again. You are getting this hairy projections are getting hairy cell leukemia. It is in males above 50 years. Now, extra learning point. You get rouleau formation in multiple myeloma. These RBC are sticking to each other. Then in multiple myeloma, you get punch lytic lesion. This is smudge cells are seen in CLL, virtually diagnostic of CLL. Question 18. A 70-year lady has pernicious anemia, which is electrolyte imbalance can happen with treatment of this patient. Hyperkalemia, hypokalemia, hypercalcemia, and hypocalcemia. Well, we can see the hypersegmented neutrophil nucleus is that the classical finding we get in pernicious anemia. Answer this question is hypokalemia. If you read 21st edition Harrison जो अभी आया है पेज नंबर 349 पे उसमें टेबल बनी हुई है उसमें causes of hypokalemia लिखा हुआ है उसमें नाम है treatment of pernicious anemia by folic acid B12. If you read description उसमें कुछ नहीं दिया कि क्या है. You read 15th edition Harrison same table लेकिन description में एक line है कि when we treat a case of pernicious anemia by folic acid B12 it lead to hypokalemia. That's all. But if you read 11th and 12th edition Harrison same table लेकिन description में लिखा है कि when we treat a case of pernicious anemia with folic acid B12 it lead to hypokalemia. The reason being when we give B12 folic acid large number of cells are being formed. Potassium being intercellular ion that lead to hypokalemia. फिर आगे लिखते हैं but why this does not happen with other deficiency anemia? Reason not known. Anyway, this is the point you should remember hypokalemia. And one more problem that happened occurs in this patient is thrombocytosis. You may even have to give aspirin to take care of this thrombocytosis. Question 19, which of the following cell type causes hypercalcemia in hyperparathyroid? Okay, which cell is most likely involved? Osteoblast, osteoclast, fibroblast, and osteocyte. Well, it's a basic science question. So before answer of this question is osteoclast. But let me tell you, there are three types of cells. If you talk about basic histology, osteoblast is a bone forming cell. Osteoclast is a bone resolving cell. At any given time in adult bone, 5% of the bone is under constant repair. Damaged bone is removed by osteoclast, repaired by osteoblast, and day-to-day activity of bone is maintained by osteocyte. That means we have three types of cell. One is the bone forming cell, one is the bone maintaining cell, or a third is the bone resolving cell. So what we say in Hindu mythology, they say, Brahmaji is the creator of universe. We have an osteoblast which creates the bone. Vishnu ji is the mentor of universe. We have an osteocyte which maintain the bone. And दुनिया से बुराई को दूर करने वाले को ऑस्टियो का शिव कहते हैं. We have osteoclast which remove the bad bone. Creator, mentor, and destroyer. Brahma, Vishnu, and Shiv. You will never forget this throughout your life. Answer is osteoclast. This X-ray finding is seen in which of the following condition: hyperparathyroid, acromegaly, Paget disease, and scleroderma. Well, it's a continuation of the previous question. I told you in the case of hyperparathyroid, osteoclastic activity is more. That cause this classical finding. It resolves the bone, and it may even have terminal fillings resolution may be there. This is all due to increased osteoclastic activity, which also lead to hypercalcemia. Extra finding brown tumors. This is codfish appearance in hyperparathyroid. This is pepper pot appearance in hyperparathyroid. Rugged Jersey spine in CRF, which is a seen a cause of secondary hyperparathyroid, not in primary. So now we have a rapid fire question because only limited time is there. I'll finish in next 3 minutes. In which of the following condition MCIC is more than normal? Sickle cell, thalassemia, heredity, and pernicious anemia. Answer is heredity spherocytosis. Which type of alcohol is most likely to precipitate acute gout? Whiskey, rum, vodka, or beer? Well, youngsters are smiling. Kya hai? Answer is beer. Beer. Okay. अब शराब की बात हो और शायरी ना हो, ये तो शराब की तौहीन है. ओके. एक शेर अर्ज है. आओ तुम्हें बताएं शराब कैसे पिलाई जाती है. आओ तुम्हें बताएं शराब कैसे पिलाई जाती है. खोलने से पहले बोतल हिलाई जाती है. फिर आवाज लगाई जाती है. फिर आवाज लगाई जाती है. आ जाओ टूटे दिल वालों, आ जाओ ए टूटे दिल वालों, यहाँ दर्द दिल की दवा पिलाई जाती है. Thank you, thank you. So now, well, in which of the following condition there can be both intra and extravascular hemolytic anemia? Only 2 minutes. Only 1 minute, 2 minutes. Yeah. In answer is G6PD deficiency. Name the nerve which has got parasympathetic supply of urinary bladder, pelvic, pudendal, hypogastric, femoral. Answer is
Dr. Bhatia, I think we will be unable to digest so much. It will be better you close. After the sherry, it was very good. We will remember.
Last question. Last question. Which of the following is not a part of classical triad of diabetic symptom? Last question. Only for reason. Not a part. Who says A, B, C, D? Answer is polyphagia. The classical triad is polyuria, polyphagia, and weight loss. Okay, but usually people talk about polyuria, polyphagia, polyphagia. आप सबने मूवी देखी होगी मुन्ना भाई MBBS. उसमें तो स्टेज पे बिठाते हैं, पूछते हैं मुन्ना भाई what is diabetes? तो मुन्ना भाई कहता है it's a state of hyperglycemia characterized by polyuria, polyphagia, and unusual weight loss. मुन्ना भाई को भी पता है. The classical triad is polyuria, polyphagia, and weight loss. Thank you very much. With a limited time.
Thank you, Dr. Bhatia. We have got one chairperson, Dr. NP Singh. He's on the line. So, Dr. NP Singh, please, on the line. You want to say a few words? Dr. NP Singh is he was professor of medicine at Maulana Medical College. Can you put you on line, please? Dr. NP Singh, please. Take him on line. Dr. NP Singh. I think is not on the line. So I request other chairpersons to say a few words.
Dr. Bhatia, sorry to stop you in between. Definitely, it was a very good quiz. I have not seen like this. And I think a postgraduate student will be benefited. Even we have been benefited.
Thank you.
Thanks a
very much.
lot.
Thank you very much. Thank you.
Thank you, Dr. Bhatia. Even there were many bouncers for us also. Collect their memento from my right side. Now I hand over the mic to Dr. Anand Jha for inauguration and lighting ceremonies. Lamp lighting ceremony.
Before wasting any time, hello. We'll go for the inauguration function. And for that, first of all, I would invite Dr. Rakesh Sood. Rakesh Sood, please come on the dais. Dr. Rakesh Sood. Then Dr. R.M. Chabra, he's the founder president. Dr. R.M. Chabra, he's the brain behind all these conferences. Dr. R.M. Chabra, please. Then Dr. P.K. Goel. He's our treasurer and the chief convenience. Hello. Dr. A.K. Malhotra. Dr. A.K. Malhotra. Dr. A.K. Malhotra is a senior consultant physician at Max Hospital. He is the vice president of North Delhi Physician Forum. And our the most senior person, respected person, Dr. Pritam Gupta, Group Officer. He is a patron of our organization. He has been a past president of API National. So Dr. Pritam Gupta. Please. Now I request Dr. Rakesh Sood to inaugurate the session. After that, we'll have lamp lighting ceremony. After this, we'll have. Chalo Sabajo. Come all the members, Dr. Rajiv Arora, Dr. P.K. Agrawal, Dr. Sureka, Dr. Amarjeet, please come. Hemant, Dr. Hemant, everybody please come. Dr. Girish Tyagi, he is the secretary DMC and past president of IMA, DMA. And Dr. Richa Devan, please. Professor Richa Devan, please. Dr. Girish Tyagi, sir. Dr. Mangla. Dr. Mukesh Bhatia, sir, please come. Dr. Tiwari, maybe Dr. Tiwari, Madam Tiwari. All are the members and active members. Everybody can come and participate in this inauguration. नेक्स्ट स्पीकर लगा दिया ना डॉक्टर मोदी को अरे सर आप भी वंदना भी थी वैस वंदना डॉक्टर अरोड़ा सर बहुत पीछे बैठे सर प्लीज अच्छा बैठिए सर नाउ आई रिक्वेस्ट Dr. Sood, Dr. Chabra, Dr. Pritam Gupta, Dr. P.K. Goel, please come on the dais. What did you Dr. No, अभी inauguration वाले का Dr. इनका एड्रेस होगा भाई तुम निकाल लाइन में हैं
चेयरपर्सन यहाँ पे क्या काम कर रहे हैं? बड़े लिखे लोग नहीं बड़े लिखे लोग हैं।
Now we have got some eminent. I welcome Dr. Grease Tyagi. He is a past president of DMA and is a presently secretary of Delhi Medical Council. I welcome him on behalf of the Not Delhi Physician Forum.